I'm Deborah Newman, physician assistant, and I serve as a treatment provider in addiction medicine and psychiatry for the First Judicial District Court, Adult Drug Court in Santa Fe and Rio Arriba counties, New Mexico. As someone who works with people with substance use disorders every day in my practice, I know firsthand how prevalent these conditions are and how important it is to be able to address substance use disorders with patients. As a future healthcare provider, you will inevitably encounter substance use disorders in your practice. It is therefore important that you not only learn about substance use disorders, but to feel comfortable and confident in providing treatment for your patients with them. In this presentation, we will provide an overview of substance use disorders, or SUD, including definitions and statistics, the scope of the crisis, causes and effects of the cycle of addiction, and approaches for treatment. The photo you see on your screen is the landscape of New Mexico that I see when I go on hikes with my dog Jake. It's a beautiful landscape, and there are lots of equally beautiful landscapes like this one throughout my state. But there is a dark side to the landscape of New Mexico. My state has consistently been ranked number 1 in overdose death rates for decades. New Mexico has also ranked highest in the rates of alcohol-related deaths in the United States from 1997 through 2010. This isn't surprising, as data has shown that many drug-related deaths are also related to alcohol. These statistics help illustrate what can happen when states have serious problems with substance use disorders. The consequences of this are many, and they are significant. They include not only death, but also domestic violence, poverty, crime, unemployment, overuse of prescription opioids, chronic liver disease, motor vehicle accidents and other injuries, mental illness, and other medical and economic problems. In 2010 alone, the economic cost of excessive alcohol use in New Mexico was $2.2 billion. The good news is there are steps states, healthcare systems, and communities can take to address the SUD crisis effectively and reduce deaths related to SUD. You, as a future healthcare provider, can also be a part of the solution. Currently in the United States, there's one topic that seems to dominate news coverage: opioid use disorder. From 2016 to 2017 alone, the drug overdose death rate increased by almost 10%. In 2017, over 70,000 people died from overdose deaths. Take a look at the overdose mortality map from the National Institute on Drug Abuse for the period 2003 to 2017. This map really illustrates the surge in drug overdose deaths during that time. Let me draw your attention to my home state of New Mexico. You'll see New Mexico has a dark spot at the top, which indicates that even prior to the opioid crisis emerging into public view, this area, that includes Rio Arriba County, was already experiencing a disproportionate number of overdose deaths. Having worked in adult drug court in Rio Arriba County, after having started my career in a federally qualified healthcare center there, I can tell you firsthand that this is a region marked by high levels of poverty and despair. For years, people with SUD in this part of the country were incarcerated instead of receiving treatment. Today, an interdisciplinary approach to this issue is changing outcomes. Unfortunately, from 2003 to 2017, more areas of the country have also seen significant increases in drug overdose deaths. The problem is widespread and has communities around the nation seeking ways to address the issue from many sectors of society. The devastating effects of SUD are not limited to the United States. The World Health Organization monitored substance use, and their data reflect that fact that misuse of both alcohol and drugs extends to a global scale. You can also see here the co-occurrence of other diseases in individuals who inject drugs, including HIV and hepatitis C. If we look at drug overdose deaths over the course of the last 2 decades, we see that deaths from a variety of drugs have risen dramatically. This CDC data shows that while overdose deaths from cocaine and meth continue to rise steadily, synthetic narcotics, which include fentanyl, have outpaced all other drugs. The orange line in the graph shows a steep surge in fentanyl-related deaths from 2014 to 2017. It is worth reminding you all that fentanyl is extremely potent and is typically used to treat postoperative pain, but in the wrong hands, it is very dangerous. It takes significantly less fentanyl than heroin to cause an overdose. Fentanyl is 100 times more potent than morphine, and it only takes a few grains of fentanyl to cause an overdose. Drug dealers might lace heroin, cocaine, methamphetamine, or other drugs with fentanyl because it can be cheaper for them. However, it is then a riskier option for people who may be unaware of what they're purchasing. I have found in my own practice that patients may test positive for fentanyl on a urine drug screen, not knowing that they have received it. Overdoses involving fentanyl may require multiple doses of naloxone to reverse that overdose, assuming the patient survives. You'll recall a statistic mentioned earlier that referred to 70,000 people in the United States having died from substance use disorders in 2017. Let's break down these deaths by sex. Using data from the CDC, we see that about 70% of those deaths were male and almost 30% were female. We should note that most federally funded surveys have only recently started to ask about sexual orientation and gender identification in their data collections. Therefore, it is not yet possible to establish long-term trends about substance use and SUD prevalence in LGBT populations, and data like those on this slide are based on a person's reported sex at the time of death. According to NIDA, LGBT persons have a greater likelihood than non-LGBT persons of experiencing a substance use disorder in their lifetime, and they often enter treatment with more severe substance use disorders. This may be due in part to the increased risk they face of social stigma, harassment, violence, and other stressors. It is important for providers to consider these factors when assessing a person's risk level or designing a treatment plan. We can also look at drug overdose deaths by age. This CDC data shows that the highest rate of drug overdose deaths occur among individuals aged 25 to 44. If we break it down into even more narrow age bands, we see that in 2017, the age group of 25 to 34 years had the overall highest drug overdose death rate. With substance use disorder occurring at such high rates, you might wonder about treatment rates. According to data from SAMHSA, shown on this slide, only 10% of people with SUD in the United States, about 11 million people, are receiving treatment. This is in stark contrast to other chronic diseases listed here, such as hypertension, heart disease, and diabetes, which have treatment rates ranging from 70 to 84%. Clearly, treatment of SUD lags significantly behind, and this is a major problem. Again, a problem that you, as a future healthcare provider, can help address. Availability of effective treatment plays a role in this gap. For opioid use disorder, or OUD specifically, MAT, medication-assisted treatment with methadone or buprenorphine, has proven to be the most effective for long-term success and recovery. Currently, only a very small percentage of prescribers, including PAs, NPs, and physicians, have received the DEA X waiver that is legally required for a provider to prescribe buprenorphine. The number of providers who can effectively treat OUD directly impacts the availability of treatment for those in need. That's why it's critically important for you to get your X waiver and fulfill any other requirements to prescribe once you graduate. In order to get an accurate feel for the SUD crisis, it's important to know exactly what substance use disorder is. The definition on your screen comes from the American Society of Addiction Medicine. One note about terminology. NIDA now promotes the use of the term substance use disorder instead of addiction to reflect the specific diagnosis listed in the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders, or DSM-5. Simply stated, substance use disorder or addiction occurs when a person's loss of control over intake of alcohol or drugs leads to health issues or problems at work, school, or home. The DSM-5 further diagnoses a substance use disorder with a severity scale of mild, moderate, or severe, based on the number of symptoms a patient is experiencing. It can be confusing to distinguish between the distinct concepts of addiction and dependence, so let's define and compare the two. A major distinction is that addiction may include elements of dependence, which is marked by the presence of withdrawal symptoms, but a person experiencing physical dependence does not always have an addiction. It's important to remember that withdrawal can happen with a wide range of drugs, not just opioids. It can happen with beta blockers, antidepressants, stimulants, and benzodiazepines, even when these drugs are prescribed for therapeutic purposes. Withdrawal symptoms can range from mild to life-threatening, for example, with alcohol withdrawal. Therefore, patient education on the risks associated with these prescriptions is important. With many substances, withdrawal can be very serious and can lead the person to resume using the drug to avoid withdrawal syndrome. You'll also see on this slide the definition of tolerance, which refers to what happens after repeated use of a drug. Now let's address the cycle of addiction. The slide on your screen illustrates the distinct phases of the addiction cycle through which people with substance use disorders often progress. After someone with substance use disorder experiences an episode of binging or intoxication, the substance begins to leave their system and they may eventually experience withdrawal and the negative side effects that go along with it. This, combined with physical dependence, can lead to a preoccupation that eventually results in more episodes of intoxication, and then the cycle repeats. It is a difficult cycle to interrupt because of the nature of addiction and the impact it has on both the body and the brain. As you just saw, the cycle of addiction is hard to break. Let's look a little closer at this. This slide from my mentor at ASAM, Dr. Corey Waller, illustrates what goes on in the brain when drugs hijack the reward system. Dopamine is a neurotransmitter involved in the reward pathway, which is released in response to natural reward and pleasurable activities, such as food, water, sex, and interpersonal relationships. Dopamine levels are elevated when the reward is greater, but when drugs come into play, they hijack this reward system. If we look at how good you feel during your best day ever as the baseline, and then look at the increased size of that feeling when someone uses, for example, marijuana, heroin, or even methamphetamine, we can see how drugs really affect brain activity and lead to the creation of this hard-to-break cycle. I want to call special attention to methamphetamine here. Deaths from meth have quadrupled from 2011 to 2017, and hospitalizations have increased 245% from 2008 to 2015. However, national attention is currently focused on the opioid epidemic and has not caught up to the rise in meth use. This is an area of growing concern and one we, as healthcare providers, need to be prepared to address. It's also important to look at the root cause of substance use disorder. Author and lecturer Gabor Mate is a retired Canadian physician with a background in addiction medicine and a special interest in early childhood experiences and trauma. He is particularly interested in the role they play in mental health, SUD, and physical ailments throughout a person's life. By asking his patients the question posed on this slide, he strives to get at the root of what people are seeking when they use substances, what outcomes they're looking for, what they're striving to achieve, or what they seek to relieve. You'll note many responses show a connection to other events in their lives and will often strengthen the connection to trauma or undiagnosed mental illness, including anxiety and depression. Let's take a look at the reasons why people report the misuse of prescription opioids in particular, with the top reason being to relieve physical pain. We're focusing on prescription drugs here because in many states, prescription drug overdose is the leading cause of death. Using my own state of New Mexico as an example, where black tar heroin is often discussed as a leading cause of death, prescription opioids do actually outrank heroin. This can help shed some light on how the opioid crisis is fueled and why it's especially a tough one to fix. Many patients begin their path to addiction through legitimate pain that they are trying to manage and become addicted to the substance that is supposed to be helping them. So it's important for us as providers to understand safe prescribing practices and alternatives to some of these medications when indicated. Environmental factors can also play a significant role in substance use disorders. Take a look at this graphic with information from NIDA. I can tell you from my own clinical practice in drug court that I see every one of these factors in my patients. You'll also note a connection back to the responses from Gabor Mate's patient responses from the previous slide. Particularly, it helped me escape from some emotional pain, a sense of connection with others, and it gave me peace of mind. So treating substance use disorders really needs to take all of this into account. For many patients, there are multiple factors contributing to their substance use, and the treatment approach should reflect that. Here is the CDC's description of prescription drug monitoring programs and how they work. PDMPs are a crucial step in identifying substance misuse and hopefully aiding in early intervention. Once you graduate and obtain your DEA X waiver, I strongly encourage you to sign up to access a PDMP in your state and take the tutorial. This is an important tool that you'll need in your clinical practice when you're prescribing any controlled substance, and its use is actually mandated for prescribers in the majority of states. In many cases, you can access valuable information as well. In my practice in New Mexico, I can access information from about 20 or 25 states. I can't tell you how valuable it is to receive real-time prescribing data. This is a win for prescribers, pharmacists, and of course, patient safety. While the systems may vary, every state has this information available. Let's now turn to best practices for treatment of substance use disorders. On this slide, we have a definition for medication-assisted treatment, which is the most effective way to treat opioid use disorder and can be very effective with alcohol use disorder as well. The definition here refers to FDA-approved medication. The 3 approved medication for treating opioid use disorder are buprenorphine, methadone, and naltrexone. Naloxone is added to buprenorphine to decrease the likelihood of diversion and misuse of the combination drug product. For alcohol use disorder, the approved medications are disulfiram, acamprosate, and naltrexone. Equally important to the mode of treatment is access to treatment. One take-home point today is the importance of integrating MAT into primary care, as that integration can greatly curb the rise in opioid-related deaths in communities across the country. Coordination of care is key. The coordination of care between the ER and a community primary care practice, for instance, is critical in keeping people safe and preventing overdose. When you can coordinate the process of care between a treatment center and the next step after that treatment center, you can help prevent someone who has received MAT from starting to misuse substances again. The U.S. Health Resources and Services Administration has made it a top priority to work with states to increase access to MAT services. Pictured here are some of my colleagues in drug court. You're going to go out into the workforce, and without a doubt, you are going to find yourself at some point face-to-face with a patient who is struggling with alcohol, illicit drugs, or prescription opioids. In that moment, it's easy to freeze and think, what do I do next? The goal of this program is to help you figure out what that next moment will be. In those moments, you will come together with your team and you'll rally around these difficult cases. You'll work together to help these individuals recognize that they may have developed a dependence or be at risk and keep them from crossing the threshold into addiction. Or, for those who already have SUD, you will help them on the path to recovery by counseling them to consider the risks of continued use and the benefits of treatment and the payback that comes with recovery. A steady job, ability to maintain a home, transportation, a chance to restore family relationships, and a pathway to better way of life. With effective guidance and treatment from healthcare providers just like you, these patients can maintain sobriety and drastically improve their health and quality of life.